Hello and welcome to our PowerPoint on nutrition. I should have gotten this thing centered before I started and I didn't, so hopefully it's going to show correctly for us all. So nutrition is vital for life and health, obviously. Poor nutrition seriously decreases our level of wellness, and it makes it a vital component of nursing. Nurses incorporate nutrition into all aspects of person-centered nursing care and are involved in all aspects of nutritional care. And this isn't going to work. Hi, everybody. Today we're going to talk about nutrition. I think there's a lot more detail in here than we need to get into, but we'll try to go over some basics. And I can say nutrition is very important because it supports life and health. Without it, we are not going to be well. So it does make it a vital component of nursing, and we incorporate nutrition into all of our person-centered nursing care. So it is important to know some aspects of nutrition. Here's our learning objectives for this PowerPoint. Take a minute and review them. And if you can speak to these and apply them to your nursing practice, then you have accomplished your learning for this chapter. I'm having issues with my mouse. Stand by. You guys can read this slide. Goodness. Our food comes from plants and animals that we eat, and sadly, probably from a lot of other stuff that's not found in nature, which could explain some of our current disease processes that we're seeing. Nutrition is science that studies food. You'll find some of the different professionals that can get their degrees in nutrition. Nutrition is one of the areas that, as nurses, we will be working closely with, especially if our patients have a disease process where they are malnourished or have a risk for being malnourished. Or maybe where they just have a new disease process and we need to have them learn more about their nutrition. Here's some different places where nutrition professionals work. Public health, food service, government, clinical. And then they broke down clinical here to say they do nutrition screenings and assessments. They do, and they definitely manage the enteral and parenteral nutrition. That's called TPN when we're giving people parenteral nutrition via IV in the hospital setting when they're unable to eat their food for whatever reason through their mouth and they have to have it via their IV. They go through and see what their current nutritional process is and where they are with their vitamins and minerals, how much protein they need, and then they design that nutrition for them. And they also provide nutrition education, as I was saying earlier, especially when they have some type of chronic process, perhaps where they need specialized, your patient needs specialized instruction. Okay, here's a breakdown of nutrients. So these are specific biochemical substances. That's what they are. They're used by the body for growth, development, activity, reproduction, lactation, health maintenance, and recovery from illness or injury. We especially require a lot of calories when we are recovering from an illness or an injury. So essential nutrients are not synthesized in the body, or they are made in insufficient amounts and must be provided in the diet or through supplements. That's the definition of essential. Macronutrients supply energy and build tissue. For example, your carbs, fats, and proteins. And your micronutrients regulate and control body processes. And those would include your vitamins and minerals. Energy is derived or obtained from the foods we consume, and it's measured in kilocalories, which we often call calories. And those are only comprised of carbohydrates, protein, and fat. If you recall from your prerequisite nutrition class, which I don't know that all of you had to take nutrition. I know I did. Carbs and protein make up 4 calories per gram, and fat is 9 calories per gram. So if you read labels, you can see what percentage of calories you're getting from each of these 3 categories. Total daily energy expenditure is all of the calories that you use, and total daily energy intake is the total calories from the food that you ate. So if you take your intake and your expenditure differences, you can determine if you're maintaining a stable weight, if you should be seeing a weight loss, or if you're gaining weight. I am having issues. Sorry, guys. Factors affecting your BMR. To stay alive and functioning, your body has to carry out millions of chemical processes, which are collectively known as your metabolism. Your metabolism can play a role in weight gain by influencing the amount of energy your body needs at any given point. Excess energy is then stored as fat. Factors that affect basal metabolic rate and metabolism are muscle mass, age, body size, gender, genetics, physical activity, hormonal factors, environmental factors, drugs, and diet. Some things you can change to alter your BMR, and some things you can't. All right, this slide breaks down body mass index charts by it kind of just tells you who is considered underweight, normal, overweight, all the way up to extreme obesity. So the ratio of weight in kilograms to height in meters squared is the formula. This provides an estimate of body fat, and it can be used as an initial assessment of nutritional status. It's not the end-all be-all, though, and I know some people don't like this formula. It can, however, just give us an estimation of people that may be at risk for certain diseases that can occur when they have more body fat. So what would some of those diseases be? I think you probably could come up with them on your own, but they're right there for you. Heart disease, diabetes type 2, hypertension, and some cancers. And sometimes this calculation can be inaccurate for certain groups of people. I know a lot of athletes it's inaccurate for, and other people that say this is not accurate for them as well. So the overweight and obese categories define differently for children and teens, which we are not concerning ourselves with in this particular block. There are 6 essential nutrients that the body needs to function properly. Nutrients are compounds in foods essential to life and health, provide us with energy, which are the building blocks for repair and growth, and substances necessary to regulate chemical processes. So we have to have these nutrients. The metabolic processes involved in these functions are complex. Subsequently, most nutrients work better together than they do alone, kind of like some of our meds. And our nutrient needs change throughout the life cycle in response to changes in body size, activity, growth, development, and state of health. Some nutrients are considered essential because either they are not synthesized in the body or are made in insufficient amounts. Essential nutrients must be provided in the diet or through supplements. Essential nutrients that supply energy and build tissue, such as carbs, fat, and protein, are referred to as macronutrients. Micronutrients, such as vitamins and minerals, are required in much smaller amounts to regulate and control body processes. So here's some more information on carbohydrates. So carbohydrates are more easily and quickly digested than protein and fat. 90% of carbohydrate intake is digested. This percentage decreases as fiber intake increases. All carbohydrates are converted to glucose for transport through the blood or for use as energy. Glucose is an efficient fuel that certain tissues, particularly the central nervous system, rely on almost exclusively for energy. So hearing that word glucose should key you to the fact that this may be part of the reason we do not want our diabetic patients to consume a diet that is mainly made up of carbohydrates, because it turns quickly to glucose and their body does not metabolize glucose appropriately. We'll learn way more about that. Carbohydrates are the sugars, starches, and fibers found in fruits, grains, vegetables, and milk products. Though often maligned in trendy diets, carbohydrates are one of the basic food groups and are important to a healthy diet. Carbohydrates are macronutrients, meaning they are one of the 3 main ways the body obtains energy or calories. Carbohydrates are classified as simple or complex. The difference between the 2 forms is the chemical structure and how quickly the sugar is absorbed and digested. Simple carbs are digested and absorbed more quickly and easily than complex carbs. All carbohydrates are converted to glucose for transport through the blood or for use as energy. When the supply of glucose exceeds what is needed for energy and for maintaining serum levels, it is stored, part of how we maintain equilibrium within our body. When glycogen stores are adequate, which glycogen is stored in the liver, the body converts excess glucose to fat and stores it as triglycerides in adipose tissue. So triglycerides, part of your cholesterol panel. Next is protein. Protein is a macronutrient that is essential in building muscle, and it's a vital component of every cell in your body. It is commonly found in animal products, although it is present in other sources such as nuts and legumes. Chemically, protein is composed of amino acids, and I think, but I can't remember for certain, that there are 20 different amino acid chains, and these are organic compounds that are made of carbon, hydrogen, nitrogen, oxygen, or sulfur, or a combination thereof. Do you need to know that? Probably not, but it's still interesting. Amino acids are the building blocks of proteins, and proteins are the building blocks of muscle. Protein foods that contain all essential amino acids are called complete proteins. They are sometimes called ideal proteins or high-quality proteins. Complete proteins include meat, dairy products, and quinoa. Incomplete proteins can be combined to create complete proteins. So beans and rice together, peanut butter and whole grain bread, macaroni and cheese. Those are all examples of putting things together in combinations to create complete proteins. The body's protein tissues are in constant states of flux. Tissues are continuously being broken down, which is called catabolism, and being replaced, anabolism. A comparison between catabolism and anabolism can be measured by comparing nitrogen intake and nitrogen excretion. A negative nitrogen balance occurs when more nitrogen is excreted than is ingested, and this indicates tissue is breaking down faster than it is being replaced. This undesirable state occurs in situations such as starvation and the catabolism that immediately follows surgery, illness, trauma, and stress. This can result in the wasting of muscle tissue as it is converted to glucose for energy. So remember, if we don't have glucose, then our body will break down whatever it needs to so that it has energy. So what happens? We lose muscle. And did you notice that it said surgery, illness, trauma, and stress? So that is why we always are monitoring our patients' protein, and we're making sure that they get excess protein when they're under the stress of an illness. So here's the protein recommendations for your variety of people that you will come across in the world, or for yourself. Older adults is 1 gram per kilogram. So I'm an older adult, so I guess that would mean I need about 65 grams of protein a day, according to this. And then look at your patient who has cancer. They require 1 to 1.5 grams of protein per kilogram. So their needs increase based on the stress and the illness. Critical illnesses, right there, 1.5 to 2 grams per kilogram. All of those show you that as you have things breaking down, you need something to replace what is being broken down and excreted so that you don't have a negative balance. All right, next up, we have protein and health. Can you have too much? Sure. Everything in moderation. I say that all the time. Too much protein can lead to heart disease, bone loss, kidney damage. Too little. I don't even know how to say kwashiorkor. I have no idea what that is. Marasmus. And then you have people in different populations that may be at risk for having a protein deficiency because they are not either able to consume enough to meet their own needs, or maybe it's anybody that has a malabsorption condition. A lot of people that have GI issues have malabsorption conditions. People that have had bariatric surgery can also have malabsorption conditions. So knowing the history of your patient can be important in identifying that they're at risk for these types of issues. All right, and now we're moving on to fats. Fats in the diets, or lipids, are, as they're sometimes called, are insoluble in water and therefore insoluble in blood because blood is mostly made up of water. Like carbohydrates, they are composed of carbon, hydrogen, and oxygen. 95% of the lipids in the diet are in the form of triglycerides, which is the predominant form of fat that we find in food and the major storage form of fat in the body. Food fats contain mixtures of saturated and unsaturated fatty acids. Which one's better? The difference in degree of saturation depends on the amount of hydrogen in the fat molecules. Saturated fats contain more hydrogen than unsaturated fats. Most animal fats are considered saturated and have a solid consistency at room temperature. Conversely, most vegetable fats are considered unsaturated, which means they remain liquid at room temperature and are referred to as oils. Saturated fats tend to raise your serum cholesterol levels, whereas unsaturated fats tend to lower your serum cholesterol levels. So, I just answered the question, which one do you want more of? You want the unsaturated fats. Here's some different examples of which ones are good for you and which ones you should probably avoid. These are the ones that you may be finding in your processed foods, your trans fatty acids. So all of those middle aisles of the grocery store where we like to go grab stuff for convenience and because it tastes good, and we like to eat that while we're playing video games, so we're sitting in a sedentary way, not getting exercise. Those are going to increase our heart risk disease. Saturated fats, there's some different examples of where you're going to get your saturated fats from. That also is associated with heart disease and some cancers. Then these up here, your mono unsaturated and polyunsaturated. These are the ones that are considered more healthy and that actually are supposed to help lower your risk for heart disease. This next slide is just a picture of the website where you can go. Oh, no, it's not. I thought it was. This is talking about modifying the fat in your diet so that you change it over from your saturated to your unsaturated fats and how it changes your total, how it can change your cholesterol. So here is a saturated fat meal versus an unsaturated fats meal. So switching from steak to salmon, good way to go. Salmon also has a good amount of vitamin E, also good for the heart. So just making small changes, not eating that crumbled blue cheese, maybe putting sunflower seeds on it instead of the blue cheese. They've got the same light Italian dressing. Avocado is a good fat. 2 strips of bacon, not so much, but hey, I like it. It's good. But I also like avocado. So if you can just substitute healthier fats for the saturated fats, you still are going to be satisfied, but your heart's going to be happier. trying to run two different screens here, so bear with me while I get to your next screen. All right, these are your micronutrients, which are vitamins and minerals. You'll find that you have vitamins that are water soluble and fat soluble, A, D, E, and K. The rest of them are water soluble. So if they're water soluble, you will tend to excrete any excess that you didn't need in your urine. Fat soluble, however, stores in the body, so you could ingest too much of these vitamins. Typically, we see that people have deficiencies in vitamins when we look at them. Your minerals, you have major minerals and trace minerals. Those make up your electrolytes and bone, and they're super important. I know we've talked a lot about electrolytes. A little goes a long way. They need to be in the normal range or they can cause issues. So here's some different conditions that require specific micronutrients for you to stay healthy or to help you improve your health. So you can just look at that. I don't feel like I need to talk to it too much. I can tell you that anytime I've had someone with alcoholism, they are definitely getting all those vitamins when they're in the hospital. I haven't had pregnancy patients. We're not talking about pregnancy till you get into block 3 anyway. Anemia for absolutely. They're short on iron, folic acid. Vitamin B12 is a form of anemia, pernicious anemia to be specific. Renal disease, they tend to hang on to certain, well, they don't get rid of waste in their, they don't get rid of waste because their kidneys aren't working. So they have to be filtered out through dialysis at the end. But we have to keep a close eye on those micronutrients. And then vitamins. Vitamins are substances that your body needs to grow and develop normally. You can usually get all your vitamins from the foods that you eat, and your body can also make vitamins D and K. Each vitamin has specific jobs. If you have low levels of certain vitamins, you may get health problems. So, for example, if you don't get enough vitamin C, you could become anemic. Also, we give people vitamin C to help them synthesize protein, and it helps with healing because of that protein. Some vitamins can help prevent medical problems. Vitamin A prevents night blindness. Vitamins are organic compounds needed by the body in small amounts. Most vitamins are active in the form of coenzymes, which together with enzymes facilitate thousands of chemical reactions in the body. Although vitamins do not provide energy or calories, they are needed for the metabolism of carbohydrates, protein, and fat. Vitamins are essential in the diet because most are not synthesized in the body, or they aren't made in sufficient qualities or quantities. The absence or insufficient use of vitamins in the body causes specific deficiency syndromes. Minerals are inorganic elements found in all body fluids and tissues in the form of salts, for example, sodium chloride, or combined with organic compounds like iron in your hemoglobin. Some minerals function to provide structure within the body. Otherwise, others help to regulate body processes. Macro minerals. Minerals needed by the body in amounts greater than 100 milligrams per day include calcium, phosphorus, sulfur, sodium, chloride, potassium, and magnesium. Micro minerals or trace elements are minerals needed by the body in amounts less than 100 milligrams per day. Micro minerals that have recommended daily intake established include iron, zinc, manganese, chromium, copper. I don't even know how to say the next word. so I'm not even going to try it. Selenium, fluoride, and iodine. Excessive soaking and cooking in water can cause loss of minerals from food. However, minerals are commonly not destroyed by food poisoning. That's interesting, isn't it? So, my mom always used to cook vegetables in water, usually frozen vegetables, until they were gray in color and mush. So, when she would drain that water off, we would eat those vegetables because they were good for you, but really and truly, they probably weren't as good for you because she cooked all of the vitamins and minerals right out of there. So, steaming your vegetables or eating them raw probably is going to be the best way to maintain the nutrition in your vegetables and in your fruits. As the major body constituent present in every body cell, water accounts for between 50 and 60% of the adult's total weight. That's always a good thing to know. Your body's mostly made up of water. About 2/3 of the body's water is contained within the cells, or intracellular fluid, ICF. The remainder is called extracellular fluid, or ECF. And that includes all other body fluids, like plasma and interstitial fluid. Total body water and ECF decrease with age. ICF increases with an increase in body mass. So, intracellular fluid increases with an increase in body mass. Water is more vital to life than food, because it provides the fluid medium necessary for all chemical reactions. It participates in many reactions, and it is not stored in the body. Like we can store calories and fat. Water, I think we can live about 3 days without water, probably less if we are in the middle of nowhere in Arizona without water. Water acts as a solvent that dissolves many solutes, thereby aiding digestion, absorption, circulation, and excretion. Through evaporation from the skin, water helps to regulate body temperature. So all of these things that water does, I feel like you probably should know those. As a lubricant, water is needed both for mucus secretions and for movement between joints. Water balance can be seriously affected when intake, such as with older adults, or output, people with altered renal function, profuse respirations, diarrhea, vomiting, hemorrhage, severe burns, etc., is altered. So anything that's going to alter your ability to either take in or keep in water is going to seriously affect your health. A calorie is next. A calorie in nutrition is a measurement of energy measured in a bomb calorimeter. Calorimeter. I don't even know how to say that word. I don't know that we need to know the word. But basically, it's defined as the amount of heat it takes to raise the temperature of 1 gram of water by 1 degree Celsius. Food is measured in kilocalories or kcals. Calories with a large C is what we see on a nutrition label. Next slide. 1,000 calories is 1 kcal. I don't know. That's fine. I feel like there's not a lot more to say about that. So there's 3 energy nutrients that provide calories. We've said this before. Those calories fuel the cells, and those are carbohydrates, which provide 4 calories. I may have said that wrong earlier in my slides. I think I did. So sorry. Carbs are 4 calories. Proteins are 4 and fats are 9. I think I said that wrong. And that's per gram. Most people should consume a majority, 65 to 75% of their calories from carbs. Lipids provide 9 calories per gram and can be generally classified as unsaturated or saturated when discussing the fatty acid makeup of triglycerides. The government recommends less than 30% of your calories come from lipids, but many nutritionalists recommend less than 20%. The newest government guidelines allow up to 35% for some populations, especially if they are the good fats, although it is not essential. Proteins offer 4 calories per gram and will be approximately 10 to 15% of most people's calories if the appropriate grams for the amount of calories is chosen. Calculating 0.8 grams per kilogram of body weight works for most average adults. So that's your calorie needs for the day. A fourth contributor to energy is a toxin called alcohol that provides 7 calories per gram, but it is not considered a nutrient. Next up is the standard American diet. So this is basically what I just said, but really and truly, you don't need to know that whole thing on the last slide. Just really know this. 15% of your calories from proteins, 55% from carbohydrates, 30% fats. But don't make all of them animal fats. Get some unsaturated in there. Here's an example of how you can figure out the calories on a food label. So your food label is showing that the total fat is 1 gram, so 1 times 9 is 9. Calories, it already says, is 80. Total carbs, 15. 15 times 4 is, what is that? 60. Protein, 4 times 3 is 12. So 60 plus 12 plus 9 is, well, it's really 81. And if you're shopping at the store and you're not shopping the perimeter of the grocery store, you're shopping those aisles in the middle, every single one of those things in the middle should have a label on it. You can look at how much sodium is in it and see the breakdown of how much of it is protein, fat, and carbs. It's enlightening to do that when you're at the store to see what you're actually consuming. Then here's the next label, which you can figure out what percent is fat when you're looking at that label. So we can look at that same label we were just looking at. I think this is actually saying if you had an average daily intake of 2,000 calories or 1,980 in this example, this is how many grams of protein you get. This is how many grams of fat. This is how many grams of carbs. And it shows you the percentage here. So if your total intake was 1,160 calories from carbs, which are 4 calories per gram, that's 59% of this person's diet in this example. Then fat is 9 calories. So they had 60 grams, so 60 grams times 9 calories is 27%. If you take that 540 and divide it into that 1,980 calories, and then the same with the protein, take the 280 calories divided by 1,980, and you get 14%. So that is how you can figure out which percent of your diet came from those 3 major food groups: protein, carbs, or fats. take a second and go to choosemyplate.gov and look through that slide or that website. It has recommended daily allowances, all the different dietary areas of vegetables, protein, fruits, and grains. So take a peek at it and start to become familiar with it, because it's a great resource to use when we start looking at different diseases that patients have, which we're going to be looking at heart disease and diabetes soon, and renal. All of those have special dietary requirements, and this is a great website to use as a reference to help educate your patients. So factors affecting food habits. We probably could just sit and list those in general without looking at a slide, but the key driver for eating is hunger. But that's not always, sometimes it's boredom, sometimes it's habit. But what we choose to eat is not determined solely by physiological or nutritional needs. Some of the other factors that influence food choice include biological determinants such as appetite, taste, and hunger, economic determinants such as cost, income, and availability, physical determinants such as access, education, skills, and time, social determinants such as culture, family, peers, and meal patterns, psychological determinants such as mood, stress, and guilt, attitudes, beliefs, and knowledge about food. I was also looking at this. I don't know if I see it, but I guess it might go under physical determinants because access. So I'm thinking if you live on a remote Native American reservation, they have little access to running water as well as little access to fresh fruit and vegetables. So I don't know, is that economic? Is it physical? Is it social? I don't know. I'm just saying that there's definitely not an equal access to healthy foods. There are so many influences. So, and it's hard to change your lifestyle when you need to either improve your eating habits or break. I'm getting a phone call. I'm just ignoring it. It's hard to break habits, like people that maybe need to exercise more and consume less so that they can lose weight to be more healthy, or the person that has an eating disorder and they have a very difficult time because there's so many factors that go into it, both physically and psychologically, to help those people overcome their eating disorders and improve their nutrition. So all kinds of things. I don't even know which risk. Where am I? Risk factors for poor nutritional status. Nutritional risk can be assessed in elderly populations by evaluating things like food intake, income, functional status, socialization, acute and chronic illness, and use of medications. And I will say that because we're focused on elderly populations, I would know those factors. Nutrition screening must become an integral component of the healthcare services provided for all older Americans. Alcohol can alter the body's use of nutrients and thereby its nutrient requirements by numerous mechanisms. The toxic effect of alcohol on the intestinal mucosa interferes with normal nutrient absorption. Thus, requirements increase as the efficiency of absorption decreases. So the more alcohol you drink, the more vitamins and minerals your body needs, is what that says in easier language. Many drugs have the potential to influence nutrient requirements as well. So nutrient absorption can be altered by drugs that change the pH of the GI tract, increase GI motility, damage the intestinal mucosa, or bind with nutrients, rendering them unavailable to the body. So, if they're taking medications, whether they are prescribed medications or non-prescribed medications, if it does any one of those things, it can change the nutritional absorption. So because some nutrients compete against each other for absorption, an excess of one nutrient can lead to a deficiency or an increase the requirement of another, especially if one is absorbed preferentially. For example, a delicate balance exists between zinc and copper. People who take therapeutic levels of zinc run the risk of developing a copper deficiency. It's not a typical thing you see unless they also increase their intake of copper. So if you see a copper deficiency, think, are they taking zinc as a supplement? I don't know how long this is, but I feel like I've been talking forever. 46 minutes already. Sorry, guys. Many factors influence our food choices, such as childhood experiences, peer influences, education, income amount, health reasons, and convenience. I feel like right now, convenience is a lot of it. Oh, there's my rural and urban residence example. Occupation, education, ethnic identity. Of course, you have certain foods that you may prefer based on how you grew up and your ethnic background. Let's see, health beliefs, health status. So some people are following a special diet. Maybe they're vegetarian or vegan. And then we have, of course, people that have knowledge about nutrition versus those who don't. And then religious beliefs. Certain religions follow a very strict diet. At times, a combination of physiologic and physical factors that influence nutrition requirements and or in combination with sociocultural and psychosocial factors can affect a person's nutritional intake. Subsequently, these factors can result in a decrease or increase in food intake. So I brought up earlier, decreased food intake could be due to a lack of appetite. We're not talking about anorexia nervosa here. We're just saying they're not hungry. Or their food intake could be increased because they are extra hungry. Consuming nutrients in excess of metabolic demands are more than needed for activity, gender, height, and weight. That's how we become overweight. So our activity level doesn't meet, we don't burn enough calories to meet what we're consuming. And next, I think you guys all get that. So here is some different things to look at when you are assessing your patients that can be indicators of nutritional status. So these are things I would know. Take a minute and look at it. And I'm going to move on to the next slide. The next slide talks about your biochemical assessment. So this is labs that you can order that will give you some more information about your patient. We've talked about this in class already. So the best indicator of someone's nutritional status truly is looking at their albumin and prealbumin serums. And let's see. Complete blood count, hemoglobin and hematocrit. That's going to tell you if they're anemic or not. Electrolytes. We get into this way in depth later. That's going to say what your vitamin and mineral deficiencies might be. And serum transferrin and retinol binding protein. Transferrin is measuring, it's a measurement of iron. It's part of the iron panel. All right, that is our next one. Let me get there. Early identification of patients at risk for malnutrition or who are malnourished is crucial in order to start a timely and adequate nutritional support for them. Nutritional risk screening, a simple and rapid first-line tool to detect patients at risk of malnutrition, should be performed systematically. Patients with nutritional risks should subsequently undergo a more detailed nutritional assessment to identify and quantify specific nutritional problems. Such an assessment includes subjective and objective parameters like medical history, current and past dietary intake, physical exam, and anthropometric measurements, functional and mental assessment, quality of life, medications, and laboratory values. Nutritional care plans should be developed in a multidisciplinary approach and implemented to maintain and improve patients' nutritional condition. So who would we put in to help with that multidisciplinary approach? You've got your nurse, your physician, or your advanced practice provider, nutrition, and then who else? Maybe some resources in the community, which we would engage case management, maybe, but probably social work. Probably social work. We might need to get physical, OT, and speech involved because maybe it has to do with their functional abilities. It just depends on what's going on. But if we determine that it's that they don't have access due to where they live or due to their economic status, then that's when you're going to get those other sources involved to say what are some different resources we could get for them that could help them with their nutrition. All right, good enough on that. This is the longest PowerPoint. I'm sorry, you guys. This is how you do the anthropometric measures. So you're looking for the waist circumference. So it's at the level of the umbilicus for the waist. Have you seen this before? It talks about body fat distribution. If you have that apple or pear shape, that poses your greatest risk for heart disease. And that's because your fat is central to the abdominal area. If your waist measurement is 40 inches or more for men and 35 inches or more for women, that's where you're starting to see a real risk for health issues. Waist to hip ratio is a tool to identify central obesity. A comprehensive nutritional assessment includes your anthropometric measures of body composition. Measurement of the size and proportion of the human body are used to determine body dimensions. Biochemical measurements of serum protein, micronutrients, and metabolic parameters. Clinical assessment of altered nutritional requirements and social or psychological issues that may preclude adequate intake, and measurement of dietary intake. That is a mouthful. Take a look at your book for clinical observations for nutritional assessment. This is the slide I thought we were looking at. Sorry. So what I just said went along with this. This slide is the one I'd like you to take a second and go to choosemyplate.gov. It's a good website. Bookmark it on your device. You'll use it later in class. And as you learn more about how to support nutrition for your patients that have specific diseases. I think it's this week that we're going to be talking about how to feed your patients with dementia. And I do want to show you guys during class a cool thing that I learned during my training at Hospice of the Valley. They do a ton of work with patients with dementia and Alzheimer's and other memory diseases. And I want to show you how they showed us to help people eat because it was pretty cool. But there's a lot of different special considerations here that I want you to take a look at. I don't need to read them to you. Your next slide is also special feeding considerations for patients with dysphagia. Remember, dysphagia is patients that have difficulty swallowing. Here's some different therapeutic diets. And you're going to need to be familiar with these because they are all diets that you're going to see throughout your nursing career if you're caring for especially our older patient population. So nephrotic syndrome, that's kidney disease. All of this renal diet due to kidney disease. So the kidneys are not working effectively, so you have to reduce the workload on the kidneys. How do you do that? Right here. Sodium restricted diet, who's that for? Heart disease. Well, and I guess acute and chronic renal disease, because we don't want them getting too much sodium. Why? You can't get rid of waste. And then your liver disease. Low fiber. Your patients that have ulcerative colitis, diverticulitis, or Crohn's disease, because fiber adds bulk, you want it to kind of move right through. Then you want your high fiber diet for your patients that have constipation. So if you have a high fiber diet, what else do you have to have? More water. If you eat a high fiber diet and don't increase your water, or you're not taking in enough, then it's going to be like concrete in the bowels. And then you have fat restricted diet. That's people that have problems with their gallbladder, or they have cardiovascular disease. And atherosclerosis, that is buildup of plaque from the fat that you're eating in your arteries. And then you have a blocked artery, which causes lack of blood flow, which causes heart disease and heart attacks or MIs. Consistent carbohydrate diet. This is where you're counting your carbohydrate content and trying to maintain not just a healthy weight, but really being conscious of what you're eating. Because if you eat too many carbs, then you're going to have issues with your blood sugar if you're diabetic or have glucose intolerance issues. All right, modified consistency diets, those are for people that are having issues with swallowing. Also, need to know that. Your older adults, age-related changes. So they lose their teeth. They have ill-fitting dentures or gingivitis. So do they have food getting stuck in their teeth? Are their dentures slipping out? Do they have their dentures with them? They have a loss of taste or smell, perhaps. Then maybe they are not eating because they can't even smell the food. I know sometimes I don't even notice I'm hungry until I say, oh my gosh, that smells great. So if I can't smell, I may not be eating as much as I should. That is not an issue for me right now. Decreased peristalsis in the esophagus. So that is when your esophagus muscles aren't functioning appropriately. So it's telling you to avoid cold liquids, try not to get upset, and take anticholinergic drugs as ordered by your physician. So these are your nursing strategies when they have these issues. And then gastroesophageal reflux, or GERD. I feel like everyone has that, including me now. And you're supposed to do all of those things, none of which I do. But you're supposed to. So do as I say, not as I do. I feel like we're getting to the end here somewhere. No, we're really not. Here's some more stuff. Things that happen with your older adults, what you can tell them to do. Definitely read through it. I'm not going to read it to you because I think you can read. And more. And this pretty much just encapsulates everything we talked about throughout this whole PowerPoint. The NG tube, that is when our patient can't eat for whatever reason, they have something going on. We put in an NG feeding tube. Not typically something we do for very long. When you put in an NG tube, we don't do this until future blocks, but you're going to ensure that it was placed correctly by confirming it with an x-ray before using it. And then we have to measure where we actually put it or where it ends. There's a specific way we measure it to make sure that we know exactly where it ends, where it terminates in the stomach or beyond the stomach if it goes into the duodenum. However, we definitely want to measure or aspirate and visually assess that aspirate to see what we're seeing. Is it contents of the stomach and such? I mentioned that we're going to measure the tube length and we're going to mark the tubing. We're going to tape it in place on the nose and we're going to mark it with a Sharpie to say how long it is, where it should be ending, because it's an easy visual to walk in and see that, oh, that Sharpie mark is now like 8 inches lower than it was. So the patient dislodged their their nasal gastric tube. Carbon dioxide monitoring and confirming tube placement. We talked about that. Some different ways we use to confirm it would be, let me think, putting air into it while listening with our stethoscope and seeing if we hear it. That is not anymore evidence-based practice so much because, I don't know, you could be in the lung, I guess, and hear it. We look at it more from the x-ray perspective. That is the gold standard. Then if we have to have long-term nutritional support, we look at G tubes and J tubes. G tubes are in the stomach and the J tubes are in the jejunum. And you can read the rest of that. I can tell you that it's important to not pull on those too hard because if you pull it out, it is quite painful. So we want to assess the area around the tube. Typically, it'll have a sponge type dressing with the slit in the side. You want to make sure that that's staying clean and dry and clean the area frequently to avoid getting a breakdown of the skin in that area. And then your enteral feedings. Follow the schedule that's provided to you in the formula. Sometimes it's by pump, sometimes it's by gravity. Keep the head of the bed elevated at least 30 degrees or higher during the feeds and for at least an hour after the feeds, because if they have peristalsis issues or they have GERD, it could be something that they can aspirate back into their lungs. Monitor for complications. So we always aspirate contents before we give them medications or before we feed them their enteral feeds, because we want to make sure that things are progressing. So let's say you pulled out 250 mLs of contents. They may be having peristalsis issues and we need to contact the physician before we shove some more in there, because we could be causing more harm than good. And always we're providing comfort measures, keep your patient comfortable, and provide education. I feel like we're done here. That only took an hour and 4 minutes. Sorry this was so long.